Alrighty, that is me. Hello, everybody. Good morning. Do you think you could make this just a tad bigger? Here we go. Perfect. Okay, the objectives of this study were pretty much to compare the efficacy of cemented versus uncemented outcomes in the elderly population for a total hip arthroplasty. Traditionally, cemented has been the choice for elderly population, but considering the advancements in technology recently, surgical approaches and increased utilization of uncemented THA has become more popular over time. We wanted to look and see, again, if uncemented approaches may be indicated for the elderly population. So to give you a little bit of background, only 1.9% of elective primary total hips for patients aged 60 to 69 utilize cemented femoral stems. So it's become pretty unpopular over the past few years. So the percentage of this has increased each decade. So the use of cemented has increased with each decade of life to 30.8% of elective procedures for patients over 90. And cemented total hips historically have been preferred due to poorer bone stock. So it just depends on the quality of the bone. Cementless implants rely on a press fit or interface fit into the surrounding bone. And because the elderly tend to have less of that surface area, the non-cemented don't work as well. So there is an increased risk of bone grafting failure in elderly patients with osteoporosis specifically, causing the femoral stem to loosen and subsequent implant failure and pain due to loosening. So the methods that we just did a simple PubMed review, non-systematic. We just looked at all of the articles that we could find and combined the data. So first that we're going to look at is how we select and the indications for uncemented total hips. The most dependent on evaluation is the bone stock, like we said before, and this is evaluated both pre and intraoperatively. So osteoporosis and osteomalacia are both contraindications to uncemented THA, and this is most commonly seen in the geriatric population, but we can see it in younger patients as well, especially females. Thicker core disease in younger patients are ideal for that osteointegration without cement and is less prone to fracture overall. Uncemented total hips have been shown to have superior long-term survival compared to cemented total hips, especially in younger patients. That's important to consider. And the final determination for candidacy of a non-cemented implant is evaluation of that intraoperative bone quality. So you really have to be in there, seeing the tuberculate, seeing the core disease to see if the patient would be a true candidate for this procedure. But overall, what literature is suggesting is age shouldn't be a determining factor in whether or not preoperatively you choose to do this or not. You just have to evaluate when you're actually looking at the bone itself. So a way that surgeons have tried to mediate the risk is using an uncemented short stem. So a short stem is defined as a stem that is less than 120 millimeters in length. It coincides with the metaphyseal-diaphyseal junction, so it sits a little bit higher in general. So what this does, and the advantage of it, there is less soft tissue damage. So it's definitely important for people who don't heal as well, so people who are older. And there is a decrease in stress shielding in the G1 region, which there is a picture in here somewhere. You can kind of see the different regions of the bone and how they are affected by an implant. It minimizes intraoperative bone loss because they don't have to do as much reaming into the medulla. There's less patient-reported mid-thigh pain, makes sense, shorter stem. And this actually has a comparable clinical performance to long stem total hips without as much of the risk. So for conventional long stems, they can't achieve reliable fixation and stability in abnormal femoral alterations, so people with abnormal anatomy. Because the wide isthmus loses metaphyseal hoop stress. So what that means is that the compression that a cylinder can exert on the space around it, it doesn't have that much because their isthmus tends to be a little bit wider. And the short stem is ideal for this kind of configuration. So the outcomes of these procedures, they're most strongly correlated to preoperative ASA, BMI, and bone morphology. So the benefits of cemented implantation or uncemented implantation is the avoidance of BCIS, bone cement implantation syndrome, which is a adverse reaction. It's almost like an allergic reaction to the cement. It's like a systemic hypotension kind of situation. And then there is actually increased feasibility of revision for this population because whenever the original implant is taken out, they don't have to dig out all that cement too and decrease the quality of the bone even further. There's also reduced intraoperative femoral fractures and blood loss as well. Some drawbacks to the uncemented approach is patients with uncemented stems have more compromised hip biomechanics, so a little bit more malrotation, higher risk of leg length discrepancy, abductor weakness, and higher risk for a limp. Cemented has a lower additional intraoperative complication risk and lower rate of the need for a transfusion. And this is kind of conflicting between studies as well. And then there's 10.4% more loosening in cementless, again, kind of conflicting between studies, but this is the overall determination. And then 7.2% more incidence of revision in cementless. In regards to periprosthetic fractures, according to the NJR, uncemented total hips made up to just about 30% of all intracapsular femoral neck fractures, and cemented made up 42%. And then a hybrid or a reverse hybrid fixation made up the rest. As far as loosening goes, prosthetic loosening rates in uncemented and cemented total hips were 26.4 and 16.8 respectively, so a little bit less than that cemented population, at a minimum of 5 years postoperatively. And accordingly, there is a significant difference in the rate of early revision. So pretty big difference in that as well. For operative duration, cementless has a shorter average operating time. So of course, less operating time is going to be less risk overall for the patient. So reduced time also leads to less thromboembolic concerns. And then that cement-induced osteolysis, implant loosening, and that bone cement implantation syndrome. All right, so to sum this all up, uncemented total hips have increased in use, they've increased in popularity, now making up the majority of total hip implants in the US specifically. And as the population ages, we're going to have to find better solutions, as OA is becoming a little bit more prevalent as the population ages. And they still have a desire for function and mobility, so we have to find a good solution for this population. In the past, cemented total hips have been preferred over the uncemented hips in this population due to poorer bone stock. However, uncemented hips do have certain advantages, and these include avoidance of BCIS, reduction in periprosthetic fractures, intraoperative blood loss, and tissue trauma. Disadvantages include higher rate of loosening, revision, and poorer osteointegration. However, as we mentioned, that short stem uncemented implant may have a superior outcome to the traditional long stem implant for these geriatric patients. It's not known whether current literature stratifies the outcomes for short versus long stems in the elderly, so we'll have to do a little bit more looking into that. But the main determinant for success in uncemented total hips is proper evaluation of pre- and intraoperative bone stock. Uncemented total hips have a really great potential in the elderly, especially with that short stem, but implant adjustments for anatomical differences found in the elderly may need to be standardized in order for us to pursue this a little bit further. Any questions?